for inviting me for this annual conference. And what I am going to talk today about the incretins, and the GIP is one of the incretins which is really less talked. However, the newer molecules which we have now in clinical practice, tirzepatide, is basically a GLP-1 and GIP both. So I think that it is better to know about the physiological part of the GIP. We all know about the GLP-1. I think when the DPP-4 came into the market, prior to that there were a lot of sessions on GLP-1, but the GIP was usually ignored. So these are my disclosures. So a word about the GIP and GLP-1 overview. So GIP was discovered way back in early 1970s. It is secreted by the K cells of the duodenum, and it is stimulated not only by the glucose but by the lipids. So free fatty acids are also important in stimulating the GIP from the gut. On the other side, the GLP-1 was discovered way back in early 1980s. It is secreted by the distal ileal L cells, and it is stimulated predominantly by the glucose. So the difference between GIP and GLP, the nutrient response in the gut for the GIP is free fatty acids and glucose both, and free fatty acid is more predominant than glucose, while for the GLP-1 it is by the glucose. So when these are released, so you can see the K cells and L cells in the small intestine epithelial cells, and these are released and they come into circulation and stimulate the beta cells of the pancreas and leads to release of insulin. A word about just to recapitulate the incretin effect, I think you all may be knowing, and I will share with you that the first incretin effect was published way back in 1903 in clinical biochemistry, where the observation was the supplementation of the duodenal extract to the patients with diabetes, and at that time there was no facility for the blood glucose estimation, so they just demonstrated there is a reduction in glucosuria. So the reduction in glucosuria by the duodenal extract in patients with diabetes was the first observation, and this was way back published in clinical biochemistry in 1903. So the concept of incretin first came in 1903. However, after the invention of the radioimmunoassay, when the insulin was measured, then the concept of the incretin effect was endorsed. So what is the incretin effect? The incretin effect is basically a difference in the insulin secretory response in response to glucose infusion versus the oral glucose load. So if you see that, if you give an oral glucose load, the insulin levels are like, even in this plot you can see up to 80 microunit per ml, as opposed to the insulin levels in response to IV glucose is only 20 microunit per ml. So the glucose levels, you can argue that the glucose levels are higher with IV glucose as opposed to oral glucose. That's why the people also did the isoglycemic profile when the similar level of the glucose were raised with oral as well as IV, and still there was a difference in the incretin response. So this incretin effect, or the insulin difference or insulin level difference between the two, is called incretin effect, and the majority of insulin release following nutrient, this is the major contributed by the nutrients. So in a fasting state there is no incretin effect, while in a postprandial state you have got a rise in insulin predominantly by the incretins. We will discuss what is the contribution of both GLP-1 and GIP in causing the incretin effect. Let us see this, what happens to incretin in people with type 2 diabetes. I think many people may not be aware that diabetes is a state where the GLP-1 is deficient, and while the GIP levels either are normal or slightly increased. So the type 2 diabetes is characterized by GLP-1 deficiency and a GIP resistant state. Why there is a GLP-1 deficiency in type 2 diabetes? It is partly attributed to gastroparesis. So because of the gastroparesis, the nutrients or exposure of the nutrients to the duodenum or to the ileum is delayed. That's why the response is less. In addition, there is people have also called about the L cell and the D cell glucotoxicity. L cell and K cell glucotoxicity. The toxic effect of glucose on these cells also contributes to decrease in the release of GLP and GIP. And lastly, the people who are going to be genetically predisposed to develop diabetes, they do have a progressive decline in GLP-1 and GIP. So these are the possible reasons for that, why the people with diabetes are GLP-1 deficient and they are GIP resistant. The reason for having a resistance to GIP-1 is possibly the insulin signaling mechanism at the beta cells. They are defective. That's why the GIP is not able to stimulate insulin even in the presence of higher concentrations of GIP. If you see this cartoon, you can see that the incretin response again is so large in healthy subjects, while in people with type 2 diabetes, the incretin response is slow this insulin response is markedly reduced as opposed to IV glucose versus oral glucose. So in people with type 2 diabetes, the incretin response is reduced. Both GIP and GLP, they do act synergistically on the beta cell. So GIP and GLP-1, they are released from beta cell and they stimulate the beta cell, and it is in a glucose dependent. I'll tell you why I do say the simple language would have been a GIP and GLP-1 induces the insulin secretion, but the word which is always used is the glucose dependent insulin secretion. I'll try to explain why this word glucose dependent has been used. This is the both GIP, GLP-1, as I mentioned, they both act synergistically on the beta cells to stimulate the insulin secretion, and you can see that when the GIP and GLP, the diamond shape, that is a green, you can see that, and that is the highest response when the GIP and GLP-1 acts on beta cell, as opposed to GLP and GIP when individually infused, the response is lesser. So that suggests that the GIP and GLP-1, when they are combined together, means when they act synergistically, you have a maximal insulin response in response to nutrients. So the post-meal hyperglycemia is better counteracted by the good incretin response. So this is to show that, as I use the word, the glucose dependent insulin secretion by the both GLP-1 and GIP, this is, I think you can all recall from your physiology, is the glucose enters into the beta cell by the GLUT2, that is glucose transport. Then the glucose is metabolized by the glucokinase to glucose 6-phosphate, and eventually the ATPs are generated. These ATPs leads to the closure of the potassium ATP sensitive channels or ATP sensitive potassium channel, which eventually leads to depolarization of the beta cell membrane that allows the calcium channel or voltage sensitive calcium channel to get opened. Calcium enters into the beta cell. This leads to movement of the microtubular microfilament system at the cell surface, and by the process of exocytosis, insulin is released. So this is a cascade of events which is happening from entry of the glucose to the release of the beta cell. You can appreciate the predominant stimulus for the beta cell mediated release in insulin is glucose. But you can see that the GLP-1 and GIP both are also seen here. The GLP-1 and GIP, they act on a different receptor that is called a GPCR, that is G protein coupled receptor. And G protein coupled receptor, and they would see the enzyme adenylyl cyclase, and you consequently also require the presence of cyclic AMP. The cyclic AMP is only produced by the glucose because the ATP is produced by the glucose, and the glucose entry into beta cell is absolutely cut off when the blood glucose levels are below 70. That's why I use the word the release of insulin in response to GLP and GIP is glucose dependent. As the blood glucose levels are below 70, there is no entry of glucose into the beta cell, so no ATP, no cyclic AMP, no release of insulin. So I think that's one of the protective mechanism. That's why you have with this class of drug no hypoglycemia or minimal hypoglycemia and no weight gain. On the contrary, if you see that there is a sulfonylurea receptor which binds with sulfonylurea binds with sulfonylurea receptor regardless of the glucose values. So the insulin released by in response to sulfonylurea is the regardless of glucose, so it's a glucose independent manner. So you must understand the difference between the two, because the GLP-1 and GIP, they are acting through the cyclic AMP, and for the cyclic AMP you require the entry of glucose, which is not there once the glucose is below 70. Let us see what is the contribution of the both GLP-1 and GIP. You can see that the incretin effect in healthy individuals in response to oral and IV glucose, but the GIP response is certainly larger or greater as opposed to GLP-1. You can see on the left hand side. So if you see that in percentage wise terms, then the GIP contributes around 2/3 of the post meal insulin secretion, the GLP-1 around 1/3, and the rest is glucose by 33%. So the whole contribution in covering the post meal hyperglycemia is the 2/3 is made by the GLP incretins and 1/3 is made by the glucose itself. Remember, glucose is the most potent stimulus to stimulate the insulin secretion from beta cells regardless of the incretins. So incretin contributes 2/3 and the 1/3 is by the glucose. So action of GIP, this is to summarize that, as we initially thought possibly the GIP and GLP-1 receptors are ubiquitously present, but in fact it is not true. So far the receptors which has been documented at the beta cells, they have a maximum, at alpha cells they do have. That's why these two molecules are also very important to maintain the crosstalk between alpha cell and beta cell. How the alpha cell and beta cell they do talk with each other, the possible mediator is the GLP-1 and to some extent GIP. Similarly, the GIP has got its presence on adipose tissue, while the GLP-1 are not expressed by the adipose tissue. Similarly, they are also present in brain. That's why there are a lot of effects on appetite inhibition, satiation. They are all mediated by the central effect of the GIP. So if you look for that, at alpha cells, I'll just summarize for you. In a healthy individual, the GLP-1 reduces glucagon. This may be the direct effect of the GLP-1 on alpha cell, or this may be the paracrine effect on beta cell, because the beta cell produces insulin and insulin inhibits the glucose. While the GIP, it increases glucagon in healthy individuals, while in people with diabetes, in a hyperglycemic state, the GIP reduces glucagon, while in hypoglycemic state, the GIP increases glucagon. At a adipose tissue, it improves insulin sensitivity, thereby it stimulates the lipoprotein lipase and promotes the eutopic fat accumulation, as opposed to diabetes is a state characterized by ectopic fat accumulation into the pancreas, liver and muscle. So this is the adipose tissue blood flow. This is hyperinsulinemic hyperglycemic clamp, and showing that there is an increase in blood flow when the GIP is infused along with hyperinsulinemia and hyperglycemia. These are the two final summary slides on adipose tissue. I think that's very important, that it increases free fatty acid re-esterification. It decreases blood glucose by allowing the entry of glucose into the adipocytes. So the more glycerol is produced, the glycerol output is increased, so the release of free fatty acids is reduced, and the triacyl glycerol hydrolysis is also reduced, so there is a more fat utilization. So to summarize, the GIP and GLP-1, because both are the contenders, on a brain, the GIP reduces the food intake. It does not have an effect on satiation, while GLP-1, it reduces food intake but increases satiety. On a subacute white adipose tissue, it improves insulin sensitivity, it improves adipocyte blood flow and increases storage capacity, thereby allowing the more eutopic fat accumulation. On pancreas, It increases insulin, it increases glucagon, while GLP-1 increases insulin and reduces glucagon. And GLP-1 reduces gastric emptying, while GIP does not have a much effect on that. I think, thank you for your patience hearing. Any questions or comments, I will be happy to answer.
Thank